Hello, everyone. Thank you so much for the invitation to be here today. I'm really excited to talk with you. So I have been asked to talk about medications and diet for ataxia in 30 minutes. So yes, exactly. That was my reaction as well. So my goal and my hope is to give you a lot of definitions and some framework for how we think about diet and medication, with the idea that every person is a little bit different, and the recommendations that I give to some patients are very different than the recommendations I give to others. But I want to give you a framework on how to think about it. And I do have a couple slides with lists of medications. So it's not all framework. But really it's to think about how we as physicians approach diet and medication management, and that way you can start thinking about that and advocating for yourselves as well when you see your physician. So this is the disclaimer slide that you have seen before, but I really want to highlight that center product, that center one, which is consult with your doctor as to whether or not something that I talk about is right for you. Because it may or may not be. Even if I mention it here today, it may or may not be right for you. And then I also have some disclosures. I do work with some pharmaceutical companies. I do consult with some pharmaceutical companies with the idea and the hopes that by working with pharmaceutical companies, we can help bring some of the drugs that they are developing to all of you. And that's our goal when we partner with pharma. So here's what I'm going to be talking about today. I'm going to be talking about medications. But first, I'm going to give a whole bunch of definitions and what the different terms that we use around medications. I'm going to talk about some basic principles, and then I'm going to run through disease-modifying therapies and symptomatic therapies. And I'm going to be giving you definitions of what that means to be disease-modifying or symptomatic. And then I'm also going to be talking about diet, some sort of basic principles and general recommendations. So in terms of, first up, definitions, symptomatic and disease-modifying. So when we say something is a symptomatic medication, that means it eases or helps with symptoms without addressing the cause of the disease. So for example, if you have knee pain from any cause, Tylenol could help the pain. If I have a headache, I'm going to take some Tylenol. That doesn't mean my headache could be caused from, bad sleep, too much caffeine, not enough caffeine, not enough water, I'm dehydrated. But either way, Tylenol is going to help me. It's not the cause. It's addressing the symptom. In terms of ataxia, symptomatic medications are things like if you have muscle stiffness, you can take a muscle relaxant. It is not addressing the cause, but it's helping you live better. It is hopefully improving your quality of life. Disease-modifying therapies are different. These delay, slow, or reverse the course of the disease. So in terms of our knee pain example, a disease-modifying therapy might be fixing the actual source of the knee pain. So maybe you need like an ACL repair, and that fixes the source. In terms of ataxia, disease-modifying therapy is to slow or stop the disease. That's what we all want. We want this disease to stop. We want it to stop progressing. Ideally, we want it even to take whatever symptoms you have and make them better. But at the very least, we want to slow or stop the disease. There is a role for symptomatic therapies, and there is clearly a role for disease-modifying. Some more definitions. So FDA approved. What does that mean for a drug to be FDA approved? So this means that the product's safety and effectiveness have been reviewed by the FDA, and its known and potential benefits outweigh its known and potential risks. Every drug, everything we do, has risks and benefits. And we can only evaluate the risks and benefits based on the known risks and the known benefits. And to be FDA approved, it means that the drug's benefits are more than its risks. And medications and devices are FDA approved for very specific indications or disease treatments. So a medication like Lipitor or atorvastatin is FDA approved for lowering cholesterol. Metformin is FDA approved to treat diabetes. Gabapentin is FDA approved for seizures. And then 4-aminopyridine, also called delphampridine, is FDA approved for multiple sclerosis. And riluzole is FDA approved for ALS. Some of you may notice that these medications sound familiar to you. But in the audience, you may not have MS or ALS or seizures for that matter. But you are still on these medications, these FDA-approved medications, I might add. But in that case, we are using these FDA-approved medications in what's called off-label use. So the label, the FDA-approved label, has a certain disease indication, but we are using this prescription drug for a different purpose than what the FDA approved. I have never prescribed gabapentin for seizures. Nobody ever does. It's not a very good seizure drug, quite frankly. It is a great drug for neuropathic pain. It is fantastic. I use 4-aminopyridine or delphampridine in my clinic all the time. I don't treat anybody with multiple sclerosis. I use it in my ataxia patients. And riluzole I also sometimes use in my ataxia patients, but I am not treating people with ALS or Lou Gehrig's disease. So essentially, many of the symptomatic therapies in ataxia are what we call off-label use. So we've talked about symptomatic therapies, disease-modifying therapies, FDA-approved and off-label use. And now I have, I think, one more slide. I think that's it, having to do with definitions. And these are definitions that surround clinical trials. And the reason these definitions matter on this page is because then it directly relates to how we interpret and how we think about some of the research studies that I'm going to be showing you about medications on the later slides. So in terms of definitions, a placebo is a substance or a thing with no actual therapeutic effect. So when we do a study, when we do a clinical trial, we will usually give patients a drug and a placebo. And the placebo is supposed to have no effect. But let's be honest, in practice, sometimes the placebo does. Because what happens is this, and I always give this story when I tell patients about placebo. When my kids get sick and they're nauseous and they throw up, I instantly feel nauseous and like I'm going to throw up any second. I can't explain it, I just do. And it doesn't, when like other people I know get sick and throw up, it's not the same. But when they get sick and throw up, I am sure I am going to get sick any minute now. So I will go ahead and take an anti-nausea medication called Zofran. And I know, based on what we all know about medications, is it takes at least 15 to 20 minutes for a medication to go to my stomach, be absorbed, and go up to my brain and have an effect. Okay? I know this intellectually. I swear, every single time I take this anti-nausea medicine, within 2 or 3 minutes, I feel less nauseous. I intellectually know this is the placebo effect, but it doesn't matter, it works every time. And so placebo is not necessarily a bad thing. We use placebo in clinic, but in a clinical trial, the purpose, our question is the drug, the active drug, any better than the placebo? And people do get better, a little better on placebo. They come into clinic, we're hopefully really nice to them. But the question about drugs, are the drugs any better than placebo? Double blind means the researchers and the patients don't know if they're taking placebo or active medication. And that's really important, because if I know that a patient's on a drug and they know that they're on a drug, everyone's going to feel better. And so the best trials are double-blind, placebo-controlled. And then we also want our study to be powered, which is the ability of a study to detect a difference if a difference actually exists. And to be powered, that means that you have to have lots of patients in the study, and which is challenging in a rare disease, right? And then endpoints are the event or an outcome that can be measured or objectively to determine whether the intervention is beneficial. So what we do in ataxia is we have a scale that we look at in terms of people's walking, in terms of their hand movements, in terms of their speech, and we come up with numbers related to that scale, and that's our endpoint. And what we want to see is that people on drug, how they do on this scale is better over time than people on placebo. That's what we look for to find out if a drug is going to be working. And then finally, principles of medication treatment. And here's an important point. Not all symptoms need to be treated. I know that, I don't mean that in a mean way. I don't mean that in a bad way. What I mean is sometimes we all have something that's a little bit annoying, but isn't worth the treatment. So it may be that we want to really actively, aggressively treat medication balance and walking. We want to be really actively treating that and working on that. But let's say once a month you have trouble sleeping. Do we really want a medication for once a month you have trouble sleeping? Probably not. Probably the answer is we're going to keep an eye on it. We're going to see how you're doing. We're going to follow you over time and then make a decision about, well, do we need to do something about this? If you're having trouble sleeping every night, that's something we need to talk about and address. But sometimes it's good when you're thinking about telling your doctor your symptoms. Tell them your symptoms. Tell them that you're having them. But then the next question is, do I want this even treated? But that being said, while not all symptoms need to be treated, if there is a disease-modifying therapy for your disease, you really should think about being on that. That's something you should be on. So disease-modifying therapies you should be on. Symptomatic therapies, it depends how bothersome the symptom is. I want to keep in mind that not treating a symptom, though, is also an active choice. And this especially comes up in terms of mental health. So taking and managing your mental health is really important to your quality of life, and choosing not to do something about your mental health is also an active choice. That should be treated, something that can help your quality of life. Whenever we guide people clinically, it's always a question of balancing risks and benefits for you as an individual. But what we use to guide us are data looking at groups of people. So we have lots of data looking at groups. How do lots of people on this drug do? How do lots of people who exercise do? I know my people who exercise do better than my people who don't. I can't tell you whether you exercising tomorrow is going to help you. I do know you exercising day after day is going to help you. But whenever we advise based on what we know from groups and how that relates to you. And while I'm talking about medication today, don't forget about non-medication treatments. So, with all of these definitions and caveats in mind, now I'm actually going to talk about disease-modifying therapies in ataxia, of which there is one. One disease-modifying therapy, which is really exciting that there's one disease-modifying therapy, because a couple years ago I would have said there are 0. So the fact that there is one is super exciting. And there's one FDA-approved disease-modifying therapy for individuals 16 years and older with Friedreich ataxia. It was approved in February of 2023. Overall, it has what's called a 50% slower disease course, also known as 3 points on this scale over 3 years. So I'm going to show you some of the data, and it definitely slows the disease course. It is not necessarily the end-all to be-all. We want something even better, but it is better than nothing. And importantly, its mechanism of action is specific for Friedreich ataxia. So if you have another form of ataxia, there is no point in you being on this drug. But if you have Friedreich's, this drug is a great drug for you. And this is some of the data. So what you're looking at here are different analyses. The one with the square around it, you're looking at number of weeks on the study. So everyone starts at week 0, and then you go out to 48 weeks, so like almost a year, basically. And what they're doing here is they're showing on the other side scale, what's called the y-axis, the up and down scale. They're showing you everyone starts at 0, because basically what they do is no matter where you are on this scale, that's your start point. And then they look at change over time. And the placebo people, the people on the sugar pill, everyone, and the people on the drug, the omaveloxolone drug, everyone got better at 12 weeks. Well, why did everyone get better at 12 weeks? Placebo effect. You come in, you feel better, you're on this drug, isn't that great? Absolutely. This is totally normal. But then what we see is over the course of the 12 to 48 weeks, the people on the placebo, those people got worse, And you can see by the end of the study, those people were worse than their baseline, the people on placebo. But the people on drug, those people were better than their baseline at 48 weeks. And there's a nice big difference between the people on placebo and the people on drug. And that's what you want to see when you do a study. And then this analysis here with the 3 points and the 6.6 points, what that is looking at is a different type of analysis, basically showing that over a longer period of time, these differences persist and get more and more important, basically, is what we're showing here. So the bottom line is one disease-modifying therapy for patients with Friedreich's ataxia called Skyclarys or omaveloxolone, and it's really exciting that we have this one disease-modifying therapy. And that's great if you have Friedreich's, so it's out there. More development is at work. But then the question is, what about everyone else in the room who doesn't have Friedreich's ataxia? So right now, for everyone else in the room, we're talking symptomatic therapies. And symptomatic therapies are really important for improving quality of life. So I'm going to talk, I have a couple different slides now on symptomatic therapies, and it kind of turns into a mishmash and a discussion of all these different drugs. But what I really want to take is a couple different things. This slide here came out, this is a study that came out in 2018, and it reviewed high-quality published clinical trials in ataxia. And based on studies that were available, they concluded that if you have episodic ataxia type 2, a medication called 4-aminopyridine seems to reduce your episodes. If you have a mixed ataxia or any of the spinocerebellar ataxias or Friedreich's, riluzole probably improves balance. I can tell you in practice, when I've tried patients on it, I would say a handful of patients have stayed on it. Most people haven't noticed a difference. SCA3, a drug called lithium, does not improve ataxia. And for Friedreich's ataxia, a drug called deferoperone probably worsens ataxia. And important to point out, this study that I'm talking about here came out in 2018, so it doesn't include Skyclarys. It wasn't an option at the time. Had the study come out now, I am sure it would have been included as a list of drugs that people with FA should be on. So the reason I put up this slide is it's talking about the actual published studies in ataxia. This is where people did these randomized, placebo-controlled studies looking at how people with ataxia do. But in practice, what we actually do is a whole bunch of off-label use. So this is what's been published, but what we actually do is a whole bunch of off-label stuff. So if people have balance problems, I consider the following medications. I consider amantadine, I consider fluoxetine, I consider riluzole. And if they have SCA3, I consider Celexa. And the reason I do that is there's some basic science data looking at SCA3 mice in Celexa. Now, we are not mice, we are human. And so we have no idea if it translates. But on the other hand, I would say that if someone has, these are medications, actually, amantadine is a medication, it's a flu medication that we use in Parkinson's. Fluoxetine is an antidepressant, and riluzole is that medication for ALS. So all off-label use, but we use them for balance. Small studies in a small group of ataxia patients have shown that they might help some of the time. For spasticity, we use medications called baclofen or tizanidine or clozoxazone, and sometimes we even use a medication that we use in Parkinson's disease called carbidopa-levodopa. And for nystagmus, which is the eye movements, we use baclofen or 4-aminopyridine or amantine. For depression or irritability, we use a bunch of the antidepressants that are on the market. And for episodic ataxia type 2, we use 4-aminopyridine or acetazolamide or verapamil. And so basically what it comes down to is if you have a symptom, discuss it with your doctor. And it might be that if it warrants treatment, there are medications that can help you. And these medications improve your quality of life. And that's really important. But in addition to the fact that there's these symptomatic therapies available, in addition to the disease-modifying therapy that's available in FA, there are a whole bunch of therapies that are in development. And this is really important, because these are the therapies that are hopefully going to be the therapies that are specific for and available to individuals with ataxia. The first one that I want to talk about that's in development is a medication called troriluzole. So it kind of sounds like riluzole, and that's because it's a cousin of riluzole, that medication I've been talking about. So troriluzole has been tested now in 2 large trials, including individuals with SCA 1, 2, 3, 6, 7, 8, and 10. The first trial was only 8 weeks. It was sort of a mixed bag in its result. And the second trial, though, didn't meet its primary endpoint. An endpoint, as I said before, was a word that we use to sort of the primary outcome measure, the thing that we're using to determine if this drug is effective or not. And it didn't meet its primary endpoint. It didn't show a difference between people who took the placebo and people on troriluzole on a specific scale. But that's not the entire story. The troriluzole story is a little more complex than that. Because what they did, this is taking all comers. If you look just at the people with SCA3, that's what this is showing here. And if you look on the bottom, it's showing number of weeks, 48 weeks. And again, if you're looking on the up and down scale, you're showing everyone started at 0, because that's everyone's individual baseline. And did they get better or did they get worse? And what you can see here is the people on placebo, the red line, those people got a little bit worse. And the people in the black line, the troriluzole people, stayed the same. That's kind of exciting, right? That's pretty cool. Because even though ideally we'd like people in troriluzole to get better, at a certain point, I'll take staying the same if I have to. I'd rather better, but if we have to, we'll take staying the same. So there's more troriluzole data to show you. What they then did, and what happens is this all then falls under the category of what we call post hoc, which means we've done the study, we've done the endpoints, and now we're going to go back and analyze it lots of different ways. And the problem with going back and analyzing things lots of different ways is if you analyze something enough, you're going to get a positive result. It's kind of like if you test something enough times, you're going to come up with something. So this is where some people would say, we believe the post hoc data, and some people don't. But I think it's important to show it to you to kind of understand what's going to happen next then in the troriluzole story. So this slide I want to show you here, because this slide looks really cool and really encouraging, but there may be more to it. So here's the story. In this troriluzole, what they did is they looked at natural history data. These were people that were not in the troriluzole study. These are people in what's called a natural history study. So what happens to people with SCA3, which is the one on the one side of the slide? What happens to people with all SCAs? And what it comes down to is people with SCA3 and people with all SCAs get worse over time, which is what we know. And so now the bottom scale is now looking at years. So from 0 to 3 years. And what you're now looking at is how much people are changing in that scale that I told you about, higher scores being worse, okay? And what you're seeing is the dark blue line is what happens in the natural history studies. These studies are people that we just follow over time. And in the natural history study, people get worse over time. For the people who are on troriluzole, though, with SCA3, they were pretty stable over 3 years. That's pretty cool. And for the people with all SCAs, including SCA3, those people, while they did get worse, didn't get worse at as quick of a rate as the people on placebos. So this is really exciting data, right? Except it's still a little more complicated because some people don't go into and believe things that are post hoc analyses. So here's what's been happening with troriluzole. Biohaven submitted what's called a new drug application to the FDA. New drug applications are the pathways to getting drug approval. And the FDA actually refused to look at the application. And that was in 2023. So the National Ataxia Foundation, many of you perhaps, encouraged the FDA to look at the data, and conversations between Biohaven, the company, and FDA are ongoing. In the meantime, Biohaven submitted an application to the European Medicine Agency, which is basically the FDA equivalent agency in Europe. And while it is not approved in Europe, the EMA has agreed to look at the data. So while the FDA right now is not even looking at the data, the EMA is. And that's where it stands. So troriluzole is a complicated story, and I think if you ask some of my colleagues, they would say they completely believe the data and they're really excited about it. And if you ask others of my colleagues, they'll say, meh, I'm not so sure. So I showed you the exciting data, but there's definitely some nuances to keep in mind. So in addition to troriluzole, there are a number of therapies under development. If you go to the NAF website, which is exactly where I got these slides from, these pictures from, it will run through each of the different SCAs and drugs that are in development. So you can look these up for yourself. I'm not going to go through every one because I have 5 minutes now to talk about diet. So diet is many things. Food and supplements are many things. Yes, they are our nutritional and caloric needs. But food is also so much more. It is cultural, it is celebratory, it is religious. It's a focal point of our social worlds. When you get together with your friends, what do? People go out to eat. That's a lot of what we do is we go out to eat. We meet for coffee, we meet for lunch, we meet for dinner, right? Every celebration, whether good and bad, weddings, funerals, all of that stuff, food is a focus point. Food is also, for many people, it's how we think about ourselves and our relationship to the world. People are vegetarians because they believe in being a vegetarian. People, I'm going to eat less meat, it's better for the planet. I'm going to not eat a certain type of fish because of sustainable, bad practices in sustainable harvesting and sustainable fishing and all of that, right? So food is many things, and yes, food is related to our health too. But keep in mind when we talk about diet, it's actually really complicated. And food is also habit. Food is also preferences. Some people have a sweet tooth, some people like salty, all of that. And in terms of the principles, going back to the idea of evidence, when I give recommendations to people, I want to provide recommendations based on evidence obtained from a randomized trial. And the complicating fact with diet is in addition to food being so many things, there's overwhelming health data and recommendations in the popular press. I took these 4 titles here from just the last 2 months in the New York Times alone. And I even skimmed out some of the ones that weren't as directly health related. So food and what we know about food and what we think about food is kind of overwhelming. So with that in mind, I wanted to apply it directly to ataxia. Bottom line is, large diet-related studies in ataxia are minimal. Some specific ataxias clearly call for specific dietary treatments and interventions, but most ataxias don't have anything specific about them at all. So briefly, gluten-related ataxia. This comes up all the time. It requires a gluten-free diet. It is diagnosed based on blood or spinal fluid. If you have been tested for a gluten antibody, and if you are negative, as far as we know, there is no need to be on a gluten-free diet. You can have your cookies and your cakes and your pizza and do whatever you want. If, however, you come to me and you say, Doc, I feel better on a gluten-free diet. Okay, that's fine. It's not going to hurt you. But at the same time, is it going to help you? I have no evidence to suggest that it is. And it may be kind of annoying because it's kind of nice to be able to eat some cookies and cakes and things at parties, right? Because again, food is social, food is cultural, food is all of those things. So there's nothing wrong with being on a specific diet as long as you're meeting your caloric and nutritional needs. But there's no need to be on a gluten-free diet unless you have clear evidence that you have a gluten-related ataxia. There are a few other rare ataxias that have very specific dietary recommendations. I listed 2 of them here. Unlikely that anyone in this crowd even has these, but if they do, there are some specific dietary recommendations that you can talk with your doctor about. Generally, the food plate recommendations are pretty good. You need sufficient protein and calories to maintain your weight. If you are overweight and with the guidance of your doctor want to lose weight, you can do so as well. Important, though, to take into account any concerns with swallowing, right? So in this population, I think there's one added layer that you all need to think about to make sure that your swallowing is okay and you're eating foods that aren't leading you to choke or cough. And as long as diet is healthy, there is no evidence either way for any particular diet. That's the bottom line. So in summary, medications can be symptomatic or disease-modifying. The only disease-modifying medication is Skyclarys for Friedreich ataxia. A number of medications are useful for symptomatic management, A number are under development. And generally, a healthy, well-balanced diet is appropriate for most people with ataxia. So thank you very much to all of you and to the other clinicians that I get to work with at the Johns Hopkins Ataxia Center. And thank you to the National Ataxia Foundation for having me.